So let's begin with a case. You are medical director at your hospital, and you would like to create a standardized screening process for obstructive sleep apnea, AOS in Portuguese, on all patients having surgery at your hospital because these patients deteriorate. All of the following have a high predictive value for obstructive sleep apnea in the perioperative setting, except stop bang score equal to or greater than 5, stop equal to or greater than 2 plus masculino, stop equal to or greater than 2 plus body mass index greater than 35, stop greater than or equal to 2 plus age greater than 50, stop equal to or greater than 2 plus neck greater than 40. So let's talk about why answer D is correct. How can you make the diagnosis of AOS at the bedside? Well, maybe this is a clue. The stop bang score has been validated in many studies. It's the most widely used clinical prediction tool for obstructive sleep apnea. 3 symptoms and 5 objective measurements. Do you snore? Are you sleepy in the daytime, or do you take a nap? Do you choke at night? And then 5 objective measures. Do you have high blood pressure, BMI, age, a large neck, or masculino? The Mallampati score. A low Mallampati score, class 1, shows a wide open airway, and a class 4 shows a closed airway. These are 2 tools that you can use at the bedside to raise your index of suspicion for obstructive sleep apnea without polysomnography sleep studies. So the high stop bang score, greater than or equal to 5, in surgical patients shows a high risk for sleep apnea. This is the work done by Dr. Francis Chung in Toronto, Canada, who is the preeminent investigator in surgical cases of obstructive sleep apnea. There is a 2-step strategy for screening. A stop score 0 to 2, no sleep apnea. A stop score greater than or equal to 5, high risk for sleep apnea. A stop bang score of 3 to 4, then you go to step 2. And this is why answer D, age is not the risk factor in the second step. Why is this important? Because we know with obstructive sleep apnea, in this systematic review by Dr. Opperer, that patients with obstructive sleep apnea have postoperative pulmonary complications, desaturation, and they are difficult intubation for the anesthesiologist. Like non-surgical patients, obstructive sleep apnea perioperatively is associated with atrial fibrillation, and they have higher resource utilization during surgery. Thankfully, in this study, there was no increase in cardiac complications and no increase in mortality. However, new research shows that patients with severe sleep apnea, there is actually an increase of 30-day cardiac complications. This composite outcome was shown in this study at 1,200 patients at 8 sites, showing almost 1 in 5 patients had the primary outcome. At 30 days, severe obstructive sleep apnea was associated with increased cardiac death, myocardial injury, and heart failure for non-cardiac surgery. How can we make these patients better preoperatively? Identify patients with sleep apnea, document it in your consult. And for those patients that you suspect sleep apnea because of their stop bank score and their Mallampati score, write suspected sleep apnea as your diagnosis. If possible, obtain the sleep study polysomnography results and the recommended positive airway pressure settings that the patient uses at home. Ask the patient to bring their CPAP, AutoPAP, or BiPAP device to the hospital and use it when the patient comes out of surgery. Document in the medical records so all members of the care team are aware that your patient has sleep apnea, and optimize other conditions that could impair cardiac or pulmonary function. Red flags. For patients that do not have emergency or urgent surgery, refer them to a sleep medicine specialist if they have the following conditions. Obesity hypoventilation syndrome. We see this with patients who you believe have sleep apnea and have an increase in the serum bicarbonate level. Severe pulmonary hypertension with right ventricular systolic pressures at 70 or right ventricular dysfunction, and hypoxemia not otherwise explained by cardiac disease. Intraoperatively, the anesthesiologist needs to plan for a difficult intubation and mask ventilation. If possible, do not intubate the patient and suggest to your colleague to use regional anesthesia or a local block. Use sedatives with caution and minimize opioids. Postoperatively, we as internal medicine and hospitalists need to minimize sedatives and opioids. Again, use regional blocks postoperatively and non-opioid analgesia. Provide oxygen until the patient can maintain their oxygen saturation on room air. Maintain the patient in a non-supine position and continuous pulse oximetry until the patient is awake and able to guard their airway. Postoperatively, continue the patient's CPAP. Start CPAP if you see the patient is getting hypoxic, and avoid continuous opioids or sedatives like patient-controlled anesthesia. After surgery, send a communication to the patient's primary care doctor that they were identified as having obstructive sleep apnea or high risk for it. Does any of this matter? How can we make things better for obstructive sleep apnea patients? This is a systematic review and meta-analysis of almost 1,000 patients with obstructive sleep apnea. The intervention was giving preoperative or postoperative CPAP versus none. No CPAP at all. The outcomes were postoperative adverse events, apnea-hypopnea index, and length of stay. There was no significant difference in postoperative adverse events with the intervention. Let's see if I can move this over. But postoperatively, the apnea-hypopnea index reduced from 37 to 12. Length of stay was decreased by 1/2 of a day. Let's do another case and change topics. 65-year-old masculino with abdominal pain. His primary care physician treated him 7 days ago for COPD, and vascular surgery would like to do an aortic aneurysm repair. He does not walk much because he does not want to go out and catch coronavirus. He has moderate COPD. He is on all of the usual medicines for COPD, and he just finished cortisona 2 days ago. He smokes. His lungs are clear, and his room air oxygen saturation is 96%. And he has a pulsatile mass in the abdomen. chest x-ray, negative. Which of the following is the most important predictor of perioperative pulmonary complications for open abdominal aortic aneurysm repair? Is it the age, location of the surgery, COPD, functional capacity, how active is the patient, or tobacco smoker?
Tobacco smoker.
Okay, good thought, good thought. So, respiratory complications are just as common as cardiac. And I know that Dr. Cohen is going to talk to you about cardiac complications, but they cost more than cardiac. Postoperative respiratory failure is a marker of poor health and further complications. Postoperative respiratory complications also increase length of stay. And even healthy patients undergoing high-risk procedures get postoperative pulmonary complications, like aspiration. So this is why respuesta B está correcta. It's procedure-related, more important than the patient-related. The patient-related risk factors are actually age and American Society of Anesthesia score. But the most important factor for pulmonary complications is the surgical site. The closer the incision is to the diaphragm, the higher the risk of pulmonary complications because of inefficient breathing, usually because of pain. This is why laparoscopic surgeries are better for the lungs, and lower abdominal surgeries are better versus higher abdominal surgeries. This is from Dr. Gerald Smetana showing that procedure-related risk factors, aortic aneurysm, surgeries of the chest, surgeries of the upper abdomen, long surgeries under anesthesia, head and neck surgery because of the airway issues, emergency surgeries, vascular surgeries, and the use of general anesthesia instead of a regional block are high-risk surgeries. This is the Gupta postoperative pulmonary complication risk index. And you can see that aortic surgeries have about the highest risk that you can have. This is the National Surgical Quality Improvement Project, respiratory failure in abdominal and vascular surgeries risk factors. Increased age, general anesthesia, the surgical procedure, shortness of breath at rest, severe COPD, poor functional status, heart failure and ascites in the last 30 days, renal failure on dialysis, steroids, cancer, and an open wound are all risk factors in abdominal and vascular surgeries for pulmonary complications. This is Ara Scott from Barcelona. This is a risk factor derived by looking at all surgeries during one calendar year in Catalonia near Barcelona. Age, oxygen saturation, a recent respiratory infection like our patient, upper abdominal surgery like our patient, duration of surgery, long duration like our patient, emergency surgeries, and preoperative anemia are all risk factors. And our patient is actually a high-risk patient based on age, based on the respiratory infection, based on the location of a surgery, and based on the duration of surgery. He's a high-risk patient. For postoperative respiratory failure, this is Periscope. Periscope is also from Canet in Barcelona. And he, again, is also an intermediate to high-risk patient, our patient that we presented in the case. What about pulmonary function tests? The current guidelines only show using pulmonary function tests for lung resection surgery. New data suggests in minimally invasive aortic valve procedures that pulmonary function tests may be helpful. They are not recommended in non-cardiac surgery unless the patient has poor functional capacity and frailty. What about frailty or fragilidade? This is a marker of physiologic decline of multiple organ systems. This, for example, is one called the Modified Frailty Index, but there's many frailty indexes, and the first ones were done by the Canadians. With frailty and multiple surgeries, you see increased risk of pneumonia, pulmonary intubation, pulmonary embolism, and respiratory failure with frailty. Let's do our final case. Grandfather is having hip replacement surgery in 4 weeks. He has moderate COPD and he can barely walk to the bathroom. He still smokes, but he's interested in quitting. He has shortness of breath after walking 100 feet. Because of his hip pain, he has developed moderate anorexia, losing weight recently. Which of the following would be good ideas to reduce his risk of perioperative pulmonary complications? Take him to the doctor for stopping smoking and make sure his COPD is optimized. Tell him to stay in bed all day and not overexert himself. Tell him not to blow out any candles, or none of the above. The answer, of course, resposta A. Sintonize a DEPOC e cessação do dambagismo. So, optimize his chronic lung disease, optimize COPD or asthma, treat respiratory infection, and postpone surgery, elective surgery, non-emergency surgery for 30 days after respiratory infection. Treat preoperative anemia. And if there's any other pulmonary risk factors, modify them, optimize them, and notify the surgeon and the anesthesiologist how long it will take to optimize them. What about smoking cessation? Well, a meta-analysis shows that smoking cessation can reduce perioperative pulmonary complications by 23% at 4 weeks and 47% at 8 weeks. So smoking cessation is good. What else can we do? Inspiratory muscle training, deep breathing exercises, chest physiotherapy, incentive spirometry, and inspiratory muscle training is good to reduce perioperative pulmonary complications. Lung expansion comes in many flavors. Incentive spirometer, deep breathing exercises, positive pressure ventilation, continuous positive airway pressure, CPAP, postoperatively are examples. Nasogastric tubes should not be used unless the patient has abdominal distension. Otherwise, nasogastric tubes can increase aspiration. Anesthesia type does matter. General anesthesia disturbs respiratory function. Regional anesthesia is better for patients who have pulmonary disease if it is okay with anesthesia. And frailty, let me teach you a new term, prehabilitation. This is rehabilitation before surgery. So for prehabilitation, you want to get the patient exercising. Exercise, exercise, exercise before surgery to make them stronger for surgery. Nutrition, high protein meals, no caipirinhas. Pulmonary optimization, incentive spirometry, and inspiratory muscle training. Stop smoking. All of these improve pulmonary outcomes. Okay, so we are at the end of the lecture. For sleep apnea, Identify patients with known or obstructive suspected sleep apnea and communicate to your surgery team, your surgeon, and your anesthesiologist. Make sure your patient is on CPAP therapy or AutoPAP or BiPAP before and after surgery. Precautions for sleep apnea. Be careful with patients who are coming for same-day outpatient ambulatory surgery with sleep apnea, because these patients will desaturate at home after surgery. Minimize opioids and narcotics for pain medicines. Use continuous pulse oximetry until the patient can guard their airway, and use oxygen as needed and positive airway support as needed. For pulmonary, identify and document those patients at risk for postoperative pulmonary complications. Age greater than 70, frailty screens, and poor functional status. Remember, the procedure site, the upper abdomen and the chest. Long surgeries, emergency surgeries, COPD, hypoxia, recent infection, sleep apnea, smoking, and a high American Society of Anesthesia class, 3 or above. Optimize lung disease, optimize lung disease, optimize lung disease, asthma, COPD, pulmonary hypertension, interstitial lung disease, optimize anemia. Stop smoking at least 4 weeks if possible. Use lung expansion preoperative and postoperative. Postpone surgery if a patient has an active respiratory infection. And again, exercise, high protein nutrition, inspiratory muscle strengthening before and after surgery. Obrigado, Brazil. Obrigado. Thank you very much. And I'm happy to take your questions.